I hate to say it, but and it kind of like will segue into what you were saying before, how important it is to do your yearly PSA check, make sure that you're getting, cancer screening done. However, ludicrous it may sound, and, men are men, right? Because,
Anything to
women,
avoid the
I
doctor.
was going to
Yeah.
say, and women, they're getting, their gynecological exams done, and they're very good about it. But,
Right.
if we have the idea that maybe we're going to have a prostate check, we'd rather, I mean, it's crazy, but, you'd rather die of cancer than go for a prostate check. Welcome to another episode of Beyond the Scale with Dr. Minera. And today I am very happy to have Dr. Brian DeCastro, who is a urologist with Innova Urology. And he specializes not only in urological issues, but also in men's health. So we're very happy to have you here, and we appreciate your time.
Thanks for having me.
All
I'm
right,
happy to
no.
be here.
Well, thank you so much. Wanted to get started with some of the questions, some of the topics that we wanted to talk about today. We were talking a little bit before off camera about urological issues and how they present in patients who actually suffer from overweight and obesity. So just to give us an introduction, why, and I'm sure the audience would like to know, why is this specialty also pertinent in this patient population?
Well, I think from a urology standpoint, what we see is as men get older, especially, and they start to put on some extra weight, you start to see that, testosterone levels go down. Patients start to experience issues with ED, decreased energy level, decreased sex drive, overall mood tends to go down. When your testosterone levels are off, you can see increased incidence of heart disease. You can see problems with glucose management. And so I think really a lot of it goes hand in hand with these urology issues that plague a lot of men as they get older.
I'm glad you mentioned that. I've always been a huge advocate of doing a thorough metabolic workup on patients. Patients come in and their objective with me is they want to lose weight, and we look for those situations or conditions that could make that weight loss challenging. I think very few people realize that it's not just about the hormonal, the physical issues, but it also has a lot to do with those risk factors that you mentioned, cardiovascular disease, and I think even although it usually is pertaining more to a woman's issue. Brittle bones or osteopenia as well in men.
For sure, yes. Yeah, I forgot to mention that. I mean, it's very true that men who have very low testosterone levels also have osteopenia, osteoporosis. And we know a lot of this stuff from, guys who have prostate cancer. One of the treatments for advanced prostate cancer is basically to knock men's testosterone to zero.
Right.
Their fracture risk goes through the roof. Their cardiovascular risk factors go through the roof, higher risk of heart attack and stroke in the patient population who's on the androgen, the testosterone deprivation therapy. So we can see kind of firsthand from that patient population how detrimental it is to have a lower testosterone level.
Absolutely. And one of the first things, when a patient does come in, I have many men who come in and ask me, hey, should I check my testosterone? And so it's one of those things we talked about, a lot of providers, are not necessarily comfortable with doing that for a patient. So if a patient comes in and they ask you, hey, Dr. DeCastro, I think my testosterone levels might be low. What kind of, questions do you ask them? How do you get to, okay, I think you're right, we should be checking this for you?
Yeah, I think a lot of people do already come to the urology clinic with these low testosterone levels, but a lot of them are told that their testosterone levels are normal. And if you look at the reference range for the lab values, what the lab test says is normal may not be normal for somebody who's in their 30s or 40s at younger ages. And so I think part of it is really just trying to get a handle on what made them want to get their testosterone checked. So the most common things I'll ask is, do you feel like you're fatigued all the time? And that's a complicated issue because there's so many factors that go into fatigue, sleep habits and things like that. But do you feel chronic fatigue? Do you have lack of motivation to do the things that you did before? Is your sex drive decreased? Are you experiencing issues with erectile dysfunction? And a couple other things that people will bring up to me is this concept of like a mental fog. They don't feel like they're thinking clearly. They also, may, I lost actually what I was thinking there. The ability to lose weight and to build muscle at the gym. So say I'm working out 5 days a week, but I'm not seeing the weight loss. I'm not seeing the muscle growth that I would anticipate. And both of those things can be signs of a low testosterone as well.
Right. So again, historically we're told, okay, when you work up a patient, you start with your interview, right? So you've interviewed the patient, you're determining, and again, this is hypothetical because usually you get them with already the diagnosis.
Right.
But if you're getting them fresh and it's like, okay, yeah, I have all these symptoms, they everything checks off. What is then, the next step in this workup? What would you suggest that it be done for them?
Yeah, so we obviously start if they don't have testosterone levels, that would be a primary starting point. Just getting the testosterone levels checked. But we do check some additional lab work with that as well. One thing we want to make sure is that there's not something suppressing your testosterone. So sometimes a prolactinoma or a tumor that secretes prolactin will suppress the testosterone. So usually check prolactin levels. In men who are still, maybe trying to have children, will check LH and FSH just to make sure that they're normal as well. So we just kind of do that basic laboratory panel.
Right.
And then from there, if we determine that somebody has low testosterone, we start to consider the different replacement options. And there's a lot of stuff out there and a lot of stuff online that guys read about. A lot of these online men's health clinics where people are getting, testosterone online, and sometimes they don't do a great job of doing that. And so it's just a matter of once we identify the problem, then kind of having that conversation with the patients.
Yeah, and I'm glad you mentioned that. I think it's important, again, that we are addressing the issue. At least somebody's out there having the conversation with our patients. I get, a lot of patients who have already gone through an online or some other type of avenue where they've already started to replace testosterone, and that's where the challenge is sometimes, because you don't know if the testosterone is low because they've been using the testosterone, and so I think that's one of the most challenging things. With some of the blood work that's done, though, and I have patients ask me, and I'm not sure how relevant or pertinent it is in making the diagnosis. They ask me about the free testosterone. They ask me about the sex binding hormone. A lot of people want me to also, and again, I think it's patient education. It's good that they advocate for themselves, but they also want to know, okay, but what are my estrogen levels?
Right.
And so are these parts of the workup, or is this more part of the monitoring of the treatment?
When it comes to estradiol, which is the estrogen level, I usually use that more for monitoring once somebody's on testosterone. But kind of getting back to the obesity side of things, when you have extra weight, the peripheral adipose tissue, the fat tissue, actually converts testosterone to estrogen, which kind of feeds the problem. And so, estradiol levels, I'm not opposed to checking those at a time. I just don't know how helpful they are in really identifying who needs to be on testosterone replacement therapy. I think I usually use the total testosterone mostly for that. I do get a lot of guys that ask about the free testosterone. I've never really felt that it was overly helpful, but if a patient does ask, I will check it. But a lot of times we'll do a calculated free testosterone using the sex hormone binding globulin and the albumin levels.
Okay.
And so the calculated number tends to be a little bit more accurate. And I find that when I do the calculated number, a lot of times what might have been low before is actually normal.
Right.
So I don't, because every once in a while I get a guy who comes to me with a total testosterone of like 600, and they're like, but my free testosterone's low. And when I usually do the calculation, it turns out that it's, in the normal ranges. But so over the years, I've never really found it to be that helpful, but I'm not opposed to checking it when patients ask for it.
The challenge for me, and especially again, just thinking while you're answering here, is I do get patients that are, of course, I do obesity medicine. They're very, very overweight. Their testosterone levels are low. how do you, is this a patient, for instance, who is obese, low testosterone, that you would automatically jump on testosterone replacement? Or do you say, well, you know what, I think lifestyle, weight loss, trying to decrease that adipose tissue and seeing if this is a quote unquote, if there is such a thing, a resistance to your testosterone? Is there such a scenario?
So I think, that's one, you bring up a good point. I mean, a lot of times we forget to mention, hey, do you want to try to just, change your lifestyle, improve your sleep habits, improve your diet, lower the amount of sugar you're taking in, work on weight loss, work on going to the gym regularly and being more active. And will that in turn stimulate your body to produce more testosterone? Mm-hmm. And so I do have guys that do ask that question and do elect to pursue that route. And I think in some cases it can help a little bit. But a lot of times what ends up happening is they're back in 3-6 months later saying, hey, I've tried all these things. My testosterone is still low. What are my options to do this? Or on the flip side, I have a lot of guys who say, I've been trying that. It's not working. I need something to help me get the motivation to get off the couch, to get back working out again. Mm-hmm. And those patients, they're more, they're ready to start something. And so we will have the conversation about what the different treatment options are.
Okay, good. Yeah, and that's the other thing I was going to ask you is is there such a thing as a deficiency of testosterone in somebody that you would even though we talk about those ranges, right? Mm-hmm. Even if they're within the normal range, it's based more on the symptomatology is what I'm hearing. So if they are, I guess, borderline, or their age is a factor in your calculation of what normalcy would be for them, for sure, they would be candidates for treatment.
Oh, definitely. And I think if you look at just if you were to graph the average testosterone level for different age groups, I mean, clearly we see that, a younger guy will have a much higher average testosterone than somebody who's in their 60s. Yeah. So, when I have a guy who comes in who's maybe like 37, 38, and their testosterone's 300, technically that's in the normal ranges based on the reference values. Right. But you would not expect a guy in his 30s to still have a testosterone level of 300. You'd expect to be more like 500 or 600. Mm-hmm. And so, in that case, there are so many people over the years have probably told him, hey, don't worry about that. Your testosterone is normal. You don't need to do anything about it. And I think I get a lot of those patients who come in very frustrated because they've been told for years that they're fine when they haven't felt fine. They've had the fatigue and the decreased sex drive and the mental fog. And when you put somebody on the testosterone that has those symptoms, it can be life changing. And I think it really is rewarding from that standpoint to have somebody who's been kind of suffering like that to then now be on this medicine that gives them their life back.
Right.
And I think that's what keeps me doing it, because as we talked about before, not a lot of providers want to deal with low testosterone. Yeah. Maybe out of fear, maybe out of just, it can be kind of difficult at times. But I think that I enjoy seeing the patients get their lives back. And so that makes it worthwhile.
Absolutely. And that's obviously, what I enjoy about doing also the weight loss and just seeing, that boost again, the self-esteem, the just, all around, like we like to say, the mind, body, spirit type of connection that you really can elevate them there for sure. Right. So, going back to the range of testosterone, why is there such a broad range? Now, I know, one of the answers is because there is what we call a diurnal or a cyclical type of measurement. And so, for the purposes of educating the audience, what about timing? What should we be doing when we're testing?
Yeah. So when you get your testosterone checked, it should always be between 8 and 10 a.m. because that's when they standardize the lab to be done. And so a lot of people will get their testosterone checked in the afternoon, and you will see a general crash in the testosterone level in the afternoon time. So we can't really use those lab values to make any decisions. Mm-hmm. So I always tell patients, make sure when you get this done that you go between 8 and 10 a.m. So that's an important part of it. And like you said, it will vary throughout the day. Mm-hmm. And you'll feel it as it varies throughout the day as well.
Oh, yeah, absolutely. That afternoon lull.
Yeah, really for sure. Yeah, I think it's a little bit of, just the time of day and the, maybe after lunch, but you can definitely feel a difference for sure.
Absolutely. So now, patients come in, we've gotten the workup done, we
Mhm.
say, okay, yeah, definitely, you have low T. What are our treatment options? Now, I know there are, again, we talked about lifestyle,
Mhm.
and I know there's testosterone replacement, but there are also some other alternative treatments that we consider, obviously, when we're looking at fertility
For
concerns and
sure.
whatnot. So what is your approach to that?
Yeah, so that's the most important first question is, are you done having kids, or do you still want to be fertile and be able to have kids again? Because that really limits which direction you can go on the testosterone replacement therapy. So if you have a younger guy in his 30s who still may want to have children, but is just, wants something done about their testosterone, we have to think about what are the fertility sparing options. There are, it's a little bit more, well, in the past it had been more challenging, but lately, one of the things that I've been using a little bit more frequently in guys who fall into that category is clomiphene. And
Mhm.
clomiphene, as you know, is something that they've used for women to stimulate egg production who
Mhm.
are having trouble having children. But what they found is that the clomiphene also stimulates the testicles and stimulates the production not only of the testosterone, but also can help with fertility issues as well. So
Mhm.
you're boosting the sperm count and the testosterone at the same time.
Mhm.
And so for those guys who are trying to have children, it's actually very helpful. Um, and kind of a step up from the clomiphene, what I've found is there's this N-clomiphene, and it's a compounded medicine that the only place locally I know I can get it from is Akina Pharmacy in Sterling. And I've had a couple of guys who I started on clomiphene. It didn't work very well. We switched them over, or their insurance didn't cover it. And
Mhm.
I switched them
Mhm.
over to the N-clomiphene. And I'll tell you, I've had a couple of guys with their testosterone was 1,000 taking the N-clomiphene,
Wow.
which I've never seen with clomiphene.
Mhm. Mhm.
So it's actually something that I've started using a lot more for the guys who want to preserve their fertility. There are HCG injections. The
Okay.
problem with
Yeah.
the HCG, I mean, they do the same kind of thing, stimulate the testicles, but
Mhm.
the problem with HCG is it's 3 injections a week.
Yeah.
And it can be costly. It's
Right.
about, I think a vial, 10,000 unit vial is about $200. And
Mhm.
you're doing about probably 1,500 units a week,
Mhm.
500 3 times a week. So while it's 3 needle sticks, it's costly. I find that patients aren't as excited about doing the HCG injections, but that is an option.
Mhm.
And there's a gel called Natesto. Basically, it's a nasal gel that you put in each nostril 3 times a day. It's not well covered by insurance. It usually has higher copays. So for those various reasons, that isn't a great option.
Mhm.
There's also been some studies that show that if you start testosterone injections with the HCG at the same time, you can preserve the testicular size and the fertility.
Mm.
So again, that's a tough sell because now you're doing 1 testosterone injection a week, and you're doing 3 HCG injections a week, and
Yeah.
you've got that cost and 4 shots a week. So that's why I kind of circle back to the N-clomiphene and the clomiphene as kind of my primary options in guys who want to preserve their fertility.
Right. And I was going to say, then add to that, their GLP-1 injection that I'm giving them once a
Right.
week, and then
Yeah.
it's then you got five. So,
Right.
um, so you mentioned something really important, and obviously very pertinent to the audience is, insurance coverage in an ideal world, and so we see all different types and, formulations of testosterone. Scientifically, though, and I get this question a lot, is the topical version versus, the injectable version. I mean, what would, in an ideal situation, what is the best, if there is such a thing? I know it's case by case, but what would be
Yeah.
maybe the best replacement?
So we kind of covered there mostly the fertility sparing options. And it's
Right.
important to note that if you strictly just went on like testosterone gel or testosterone injections, that your sperm count would essentially go to zero.
Okay.
And a lot of people, it's kind of counterintuitive. People think, oh, I'm getting testosterone, I should be more fertile.
Yeah.
But it's actually quite the opposite. Your brain basically gets a signal that your testosterone level is high from the out of body testosterone you're getting, and that brain says to the testicles, hey, shut down production. And part of that is it shuts down the sperm production as well.
Mm-hmm.
So kind of an unintended consequence of being on the exogenous testosterone. And so that is why you have to kind of really have that discussion up front. And I've had guys come to me for fertility evaluations because they can't have a kid, and we find out, well, the guy's been on testosterone injection for years and nobody told him that was a
Wow.
side effect.
Yeah. Yeah.
But kind of getting to the, kind of our standard treatments for low testosterone and guys where fertility is not a concern, we have our primary is probably the testosterone injections.
Mhm.
They're the
Mhm.
cheapest. They're the easiest. They're mostly guaranteed to get your levels where you want them to be
Mhm.
with minimal adjustment. So that's probably the most common thing that guys are on. And I would say obviously the downside to the injections is going to be you have to give yourself an injection, or you have
Right.
to find someone to give you an injection.
Mhm.
So that would be maybe the limiting factor. But nowadays, even if insurance doesn't cover it, I mean, with a GoodRx coupon,
Mhm.
for those of you who don't know what GoodRx is, it's just an app or a website that you can go to and check your generic meds and get a very cheap price
Mhm.
for free, basically. And so you can get a prescription of 12 vials of testosterone, which could last you 6 months for about $120.
Oh wow, it's
So I
really
mean,
really
and
accessible.
that's
Yeah.
no insurance, so
Mhm. Mhm.
that's actually kind of been a game changer as far as testosterone replacement. It's made everything a lot easier.
Right.
So if we have any hassle or pushback from the insurance company, I usually kind of steer patients in the GoodRx direction.
Right. Right.
You have the testosterone gels,
Mhm.
which are probably the easiest because basically a couple pumps in your hands and then you just kind of apply it to your shoulders like you're putting on sunscreen. And you do that once a day. You just have to be really careful because the gel that's on your hands can obviously,
Yeah.
get onto other people. And if you have kids or, your
Right.
spouse, you don't want them absorbing your testosterone.
Right. Right.
And that's why I put it kind of under the t-shirt area as
Mhm.
well. So that,
Mhm.
as it gets absorbed, it's not coming into contact with other people. But that's a big downside. And for a lot of younger guys who like maybe in their 40s or 50s, I have a 9-year-old at home, it's not something, it'd be
Right.
something that could be concerning to them. And so that'll steer them away from the gels, but that's also a great option,
Mhm.
especially for the guys who are afraid of needles or who don't want to be bothered with needles.
Right.
What I see with the gels is it's kind of hit or miss. Some guys have a great response to the gels and their
Mhm.
testosterone 600 or 800. Other guys will go 2 pumps a day, 3 pumps a day, 4 pumps a day. Their testosterone still in the 200s. I
Mhm.
can't quite figure out why. That's the case, why some guys have such a great response and other guys don't. Maybe their skin doesn't absorb it as well.
Yeah.
Maybe they work out in the sun all day and they sweat it off and it doesn't
Mhm.
get absorbed. But it's not as reliable as the injections.
Right.
There are other things out there. There's Jatenzo, which is a pill.
Mhm.
It is still brand name. So the thing you deal with there is the insurance company, the poor copay. And typically sometimes the copay can be $400-$600 a month.
Wow. Yeah.
So for me, it's not been a great option yet. I mean,
Mhm.
someday
Mhm.
maybe when it goes generic or the copays come down, or maybe some people have a little better insurance, they want to try to run it, we can. But
Mhm.
a lot of times the Jatenzo is limiting by the cost.
Is it
Um,
effective though? As
it is
effective? You've seen
effective.
that? Yeah.
I
Yeah.
mean, I still think testosterone injections are the
Mhm.
most effective at
Right.
reliably getting those levels up. But the pill you do take twice a day.
Mhm.
And so it's a little bit more difficult to remember to do that. And,
Right.
there is some, I would say, convenience in getting a shot on Sunday and then,
Mhm.
not having to think about it till next Sunday and getting your
Right.
shot
Right.
again. So I think the Jatenzo is an option. You'll see a lot of guys who come in asking about the pellets.
Yes, I'm glad you
And
mentioned that because there are a lot of other maybe non-conventional things out there. I'm glad
right.
you mentioned.
And the pellet therapy does work, and kind of along that same lines of the pellet therapy is the Aveed injection. It's like a 3 month, and it might not be quite 3 months. I don't really use it very often, but
Mhm.
I think it's a 10 week shot. But you get that kind of same idea when you put them in initially, the pellets in, or you get the injection, you get this big spike in your testosterone.
Yeah.
But as the 3 months of the pellet kind of go on, by about the end of the 2 month cycle, your testosterone's basically back down in the lower 300 level for that
Mhm.
last month.
Mhm.
You also, have to put in the pellets, sometimes 9 pellets at a time every 3 months. So you're kind of tunneling this under your abdominal skin in different places. And,
Mhm.
there was at one point, I think it still exists, a black box warning on the pellets for that reason. A lot of scar tissue, chronic pain,
Mhm.
pellets coming out, infection of the insertion area. It's never been my favorite. I haven't really gotten into it. I do know people who do the pellets if somebody's interested in that,
Mhm.
in the area, but not my favorite choice. And same with the Aveed shot. I mean, there's a risk of a embolus, oil embolus, and so that kind of turned me off a little bit. And the fact that by the end of the shot cycle, you're kind of basically down in those lower levels.
Mhm.
And kind of getting back to, we've evolved over the years on just the basic testosterone injections. I mean, at one point, guys were getting one shot once a month, but you'd see the same thing, the spikes and the crash.
Right.
And then when I first started doing it, I'd have guys doing 1 ml, 200 milligrams every 2 weeks.
Yep.
But then I get a lot of guys coming in saying, you know, it's 7, 10 days saying, you know, I was doing great for that first week, but now I had a crash.
Right.
And so over time, basically, I kind of evolved to now most of the guys I just put on 0.5, 100 milligrams once a week. And that seems to be kind of the sweet spot where you don't get the spikes, you don't get the crash.
Right.
And everybody's kind of happy on that level.
It's interesting because I recall, you know, every time because again, you know, we talked about more people should be comfortable with doing, you know, the testosterone deficiency workup, starting patients on the medication. I remember specifically, you know, when I was, you know, taught it was that 200 milligram, you know, every 2 weeks. It was after I had a conversation with you that it was, you know, my standard was to go to 100 every week. And I recall also the monitoring of it. That's another thing, you know, I think is very important is that patients, you know, have to realize, okay, it's not, you're committing, right? You're committing to treatment just like we do with obesity medicine as well.
Right.
It's not just about, you know, just give me my medication and I'm going to go on my merry way.
Right.
They should be monitoring these things. You know, they're obviously ways of being able to monitor if the medication is really working as it should and I remember, you know, our conversations about checking peaks and troughs, which is something that I'd like you to mention as well.
Sure.
And then afterwards also, you know, so, and what other parameters are we looking at? Because there are some consequences, especially metabolically, you know, hemoconcentrations, we're looking at, you know, PSAs, lipids, things like that. So how do you monitor once, again, you've chosen your route of replacement, now what am I doing to check on these numbers?
Yeah. So yeah, I mean, that's a very important part of this as well. And you're right. I mean, I think the guy's mentality is I just want my testosterone and I'm going to kind of go on my merry way. But really we have to monitor things because there are a lot of potential side effects from being on the testosterone replacement therapy. And that's where I have a lot of problems with the online companies that do this is because it's just too easy to get the drug without following up. And you see guys on really very high doses that they shouldn't be on. And I want to get back to that point because I don't want to forget that, you know, once you get to the other side of things, if your dose is too high, you start to see negative consequences.
Right.
So kind of getting into the lab monitoring. Once I start someone on testosterone, you know, initially what I'll do is I'll wait about a month and then I'll repeat a panel of labs. And just to see, you know, is this a good dose? Is the testosterone working? How do patients feel at 1 month? And once, if everything's going good, the levels are good, they're happy, then it's just an every 6 month monitoring. So every 6 months, we get a panel of labs. And I think, you know, with testosterone being a controlled substance, the DA will only allow us to give a 6 month prescription at a time. So it's kind of a general reminder, hey, my prescription is running out. I'm at my 6 month labs. So what I usually do is just have patients, the only requirement I have is that they come in twice a year. Every 6 months to get their labs and get their refills. And that just helps keep track of everything because otherwise it's too hard to keep track of everybody and who's got labs and when they've gotten them done. And so kind of getting more specifically into what labs are we checking and why. So obviously we're checking the testosterone level because we want to make sure the levels are good. But I do monitor the estradiol levels because what can happen is if your dose is too high, your body will start to convert that testosterone to estrogen. And then when your estradiol levels go too high, you're going to counteract the benefits of the testosterone. So you're going to start seeing negative side effects of the high estrogen levels. So that's an important point. And what I find with a lot of these guys who come from the online clinics is they're getting, you know, maybe 200 milligrams a week, but their estradiol is like 80 or 100 and they don't feel great because it's just too much. And so when we scale that dose back, we can bring those estradiol levels down and in the end they're happier. We also monitor the hematocrit. So you kind of alluded to the idea that the red blood cell count, which, you know, red blood cells are what carry oxygen to the body. And, you know, obviously to some degree, having a higher red blood cell count is not terrible. The opposite of that's anemia. But at some point, the blood becomes too thick, and then we have to worry about, you know, could somebody have a stroke? And so obviously, we don't want to let that number get too high. And that is probably the number one thing that I see on testosterone replacement. I would say a lot of guys, their numbers start to creep up. And the most common thing I have to tell people is, hey, go over to the Red Cross, donate a unit of blood, and you'll keep that level down. And really, if guys donate blood about every 6 months on the testosterone replacement therapy, it usually keeps the numbers down.
Mhm.
And it's really a simple fix. I think people get really worried about it, especially primary care providers who are doing testosterone. That we got to
Right.
stop the testosterone. You don't necessarily have to stop the testosterone as long as it's not too high and you can get them over to donate blood.
Right.
It will get that number down and keep it down.
Mhm.
And it's kind of a win-win, right? They're going and donating blood and giving to the community and also
Exactly.
keeping their levels lower.
Good.
And then we also do, you had mentioned before, PSA. PSA is the screening test for prostate cancer, which while we're on Men's Health, make sure you're getting your PSA checked
Yes.
once a year because you don't want to end up like Joe Biden. I don't know how the president of the United States doesn't get his PSA checked every year, but
yeah.
kind of shocking.
Busy.
Yeah, maybe busy. Yeah. So there's a lot of negative publicity out there about PSA, but it still is our best screening test for prostate cancer.
Mhm.
And nowadays we can kind of pair that with prostate MRIs. And so we've eliminated a lot of the unnecessary biopsies. We've really been able to target who needs a biopsy and do targeted MRI fusion biopsies on those patients, which have made the biopsies very accurate. We're doing them transperineally. So a lot of the fear was infection after the prostate biopsy. Since we started doing them that way at the Shark Cancer Center, I don't think any of the 5 providers have had a single infection from a prostate biopsy. So just kind of a plug there for prostate cancer screening. And that is something we monitor when patients are on the testosterone because we know, as I mentioned before, testosterone is a fuel for prostate cancer.
Mm-hmm.
And one of the treatments is to starve the cancer of the testosterone. And when we do that, a lot of times the cancer can go into remission. And so that is something the testosterone is not going to cause the cancer, but it is testosterone sensitive and will grow in response to the testosterone. So if we do see someone's PSA go up, that is one time we do have to stop it.
Okay.
And kind of investigate that first. Yeah. And the first step, like I mentioned, would be a prostate MRI just to see, is there something there that we're concerned about? Mm-hmm. But that is probably the hematocrit and the PSA are probably the most important tests that we do in the monitoring. And then the other thing that I still we may not need to really check anymore, but it may be just out of habit. I still check the liver function test to make sure that we don't see any big changes there, but it's not typically something that I see with the testosterone replacement. It was more for the old oral testosterones that were out there that cause some liver problems. And I think another thing that people tend to worry about with testosterone replacement is this idea that it will make the prostate grow and cause worsening urinary symptoms. Hasn't really been much of an issue.
And I'm glad you mentioned that. So just going with monitoring, kind of touching on that again. I hate to say it, but and it kind of like will segue into what you were saying before, how important it is to do your yearly PSA check, make sure that you're getting cancer screening done. However, ludicrous it may sound, and men are men, right? Because
anything
women,
to avoid the doctor.
I was going to say, and women, they're getting, their gynecological exams done, and they're very good about it. But if we have the idea that maybe we're going to have a prostate check, we'd rather, it's crazy, but you'd rather die of cancer than go for a prostate check. Yeah. How pertinent is a prostate check, these days? I know there's been, there were recommendations for, recommendations against, evidence, saying that, it may cause more harm than not. What is the new, I guess, or the standard?
Yeah, I would say that I've had this discussion recently with my partners, and kind of the consensus is that we've all kind of stopped doing the finger exam, the prostate exam that everybody fears. And I think really that's been replaced by MRI. Right. So we have, if the PSA becomes elevated, then now we're just getting an MRI pretty much, and everybody comes in with a high PSA. And the MRI is so detailed. It's looking at the capsule of the prostate to see if anything has gotten out. And so, our prostate exam was very limited to begin with. We were feeling maybe a small surface of the prostate, and, the majority of the cancers may be on other sides or edges of the prostate we're not even picking up. And for the most part, it was very rare to have somebody come in with an abnormal exam and a normal PSA where we're getting a biopsy of cancer. Certainly we all have, a patient here or there over 20 years. I can think of maybe 2. But is it worth doing a prostate exam on everybody for that? Probably not. And so I think a lot of us have gotten away from doing the prostate exam. Now, if somebody comes in with a high PSA and, we're going to do a prostate biopsy, a lot of times while they're under anesthesia, we will do the exam for the staging purposes. And sometimes a lot of the trials require a prostate exam for prostate cancer. So we're still doing it to document it at that point. But obviously, the good news is you're getting your prostate biopsies now asleep, and you're getting your your exam asleep. So it's not like the old days where we're doing both of those things with patients awake in clinic.
Exactly.
And so, I mean, I think not everybody out there is still, I would say the majority of urologists are probably still doing the biopsies awake in clinic, but we've kind of moved on from the traditional transrectal biopsy to this, what we call transperineal. So we're going through the skin, patients are asleep. And in almost every case, we're doing a targeted MRI biopsy now. So we find the spot on the MRI, and then we're using we're fusing the images together with the ultrasound and actually targeting that spot specifically, which has made the biopsies very accurate. And the infection risk, like I said, is almost zero. So it's been a and patients are asleep, so they're happy. So it's been a very positive change overall. I can't believe we weren't doing the biopsies this way all along. But yeah, it's something so that for the patients out there, it's very important to get your PSA checked, and it can save lives. It's really crazy, but I think 3 patients this week alone. One guy's PSA was 192.
Oh, wow.
Normal PSA being less than 4.
Yeah.
I had another one that was 162, and another one was 286.
Wow.
And I can't believe that in this day and age with prostate cancer screening that I saw 3 patients in 1 week with potentially now metastatic prostate cancer.
I mean, like you mentioned, I mean, and again, it's not, it's not mentioning it lightly, but if, the president, ex-president of the United States, for some reason, allowed, or this happened to him, I mean, how does it not happen to more people,
And the only thing I'm glad you brought that point up, because the only thing I could think of is that if you look at the guidelines, a lot of the guidelines out there say that we should stop checking PSAs in guys who are over the age of 70.
Yeah.
But I think if you look at our population in general, I mean, I have a 90-year-olds who can walk 2 and 4 miles a day.
Yeah.
And to say that just when they turn 70, hey, we're just not going to check, we're not going to do prostate cancer screening anymore. I mean, that seems crazy. And I think that may have been possibly what happened to Joe Biden. His age was such that they just said, oh, we don't need to check the PSA anymore.
Right.
But I think he's another example of why that doesn't really make sense.
Yeah.
I think we should look at each patient individually.
Absolutely.
I mean, there are 50-year-olds who've had triple bypasses and are, very obese and, may not live another 10 years, whereas we have 70, 80, 90-year-olds who are walking 2 miles a day and are healthier than most 50-year-olds. I mean, they still need to get their PSA checked.
Right.
And I think kind of the idea is once you go down that road, that road that you're kind of stuck with it, you have to have a biopsy. Well, no, I mean, you get a PSA, we have a discussion. This is what your PSA, this is what your risk is. We're going to get an MRI. This is what your risk is from the MRI. Do you want to watch this? Do you want to have a biopsy? You're not locked into anything at any point.
Right.
So it's just a simple blood draw, and you're getting labs anyway. So
right.
It really has never made any sense to me why we wouldn't check the PSA.
Yeah. And thanks for that. I mean, I appreciate it, because I think, one of the things that we have to, that dispel that theory of, if you're coming in, you're going to have to get checked. No, come in, get your blood work done. Don't fear getting yourself screened.
Yeah, for sure.
And again, I mean, I think it's very important for us to be very, leery of anything that's hitting our feeds. Again, ask the questions. See your primary care doctor, and most physicians, I think, are going to recommend that you stick with the evidence based. Now, I know a lot of treatments that weren't evidence based then become evidence based, and so I mean, I think it's good to inquire. It's good to have that intellectual curiosity, but then remember, these are going into your body. It's not just because it's all natural doesn't mean that it's all safe, right?
Right.
So, yeah.
One thing I've been reading a lot about lately, which is not something new, has been around forever. If you went to any big bodybuilding gyms, everybody's doing creatine.
Yes.
But you're seeing a lot of evidence coming out now that is actually very beneficial.
Yeah.
So, I'm starting to kind of be a believer in the creatine. And I mean, there's a lot of good studies. And I think a lot of the gym guys knew that a long time ago. But that's kind of an example of what you're talking about.
Yep.
Sometimes when you do get, do the studies, you do see that, hey, some of this stuff does actually work. So, it's hard to say one way or another unless these things are studied. But, I think, sticking to what we know works is always better.
And I'm glad you mentioned that, as a side as well. There are a lot of studies that support the, I guess the practice of trying to maintain, sustain, and maybe even promote lean body muscle or lean body mass development. And so I think that a lot of the studies that are actually supporting the use of creatines and what we call BCAAs, your branched chain amino acids, are in support or in pro of preservation of that lean body mass or that lean muscle mass. As we age, and also with testosterone, and because we're talking about the urological topics, sarcopenia is a real thing, which means loss of muscle mass, which affects, you know, your function in general and your overall metabolic health.
Right.
And I think that if you look at metabolic health and those things that are deficient, you know, it all ties in together. That's why, again, you know, just to emphasize, testosterone is so important. We do also talk about, you know, even if it's a mild or a small replacement in women as well, we see definitely a benefit in the redistribution of body fat from, you know, the abdominal distribution of body fat to, you know, get rid of that less central type of obesity, and in women who also, because of the hormonal shifts, have a tendency towards what we call sarcopenic obesity, being obese, or by definition having excess body fat as a function of having decreased muscle. Testosterone plays a very, very important role.
Yeah,
sure.
and kind of along those same lines, you know, I've been reading a lot of studies lately that talk about the best way to prevent aging is with building muscle.
Yeah.
You know, and we're not talking about going out and being an Olympic weightlifter.
Right.
You know, just some light weights, repetitions, but keeping that muscle tone. And I think, you know, something as simple as body weight exercises, push-ups, air squats, sit-ups, things that can kind of just keep your muscle tone. And if you think about a lot of the activities of daily living that you do, bending, squatting, carrying groceries, you know, all that requires you to use your muscle. And you know, I think that they found that the people who have good muscle tone tend to live longer and live healthier, happier lives. So there's always been this push, I think, in America for cardio and things, but we always forget that weightlifting side of it and the building of the muscle mass. And I think that's a very important thing for patients to, you know, to incorporate into their workouts.
Absolutely. Yeah, so hopefully people are, you know, paying attention to this and realizing that it is much more than just, you know, your physical build. It has a lot to do with your metabolic health, which brings me to, you know, one of my, and you know, I'm pretty sure that this is going to, you know, trigger a lot of questions. I'm very hopeful that in the future we can have you back, you know, to answer some of those questions for us. But in closing, I guess one of the things that, you know, I find fascinating is, you know, reasons why patients will visit, you know, the physician's office. One of those that is in, you know, basically I guess the bread and butter of what you do for a living is erectile dysfunction. In men, of course, a lot of them will, you know, again, go to the online things, you know, and I'm not going to mention names, but, you know, you have all, again, being bombarded constantly with all these pills to help you with ED. As a primary care doctor and as an obesity specialist, you know, the red flag for me is not really that they have ED; it's why.
Right.
You know, so you look at all those metabolic influencers and whatnot. Patient presents to you and says, "Hey, doc, you know, I'm here because I have ED." I mean, you know, what kind of red flags does that raise for you, and what do you look at before just giving them the little blue pill?
I think it really goes hand in hand with testosterone, because I think a lot of the guys who come in with low testosterone levels will have ED issues. So I think, you know, for somebody who comes in with ED, I'll ask them the questions: how's your energy level? How's your sex drive? Have you had your testosterone checked? So that's one thing we check right off the bat. But another thing to really keep in mind, especially in kind of, you know, we see a lot of ED in diabetics and guys who are overweight for the various reasons. You know, diabetics, you know, patients with metabolic syndrome or diabetes and obesity will tend to have low testosterones. And then as a result of both things, will have ED. And so it all kind of goes together. And I think you have to also keep in mind, if the blood flow to the penis is not that great, the blood flow to the heart's probably not that great either, right? So those changes from being a diabetic, from being overweight, the high cholesterol can lead to coronary artery disease. So we have to make sure that, patients who are coming in with new onset ED who have those risk factors, who are in that age group, that they're getting screened for heart disease, whether or not that's with a stress test or an EKG, something, the CT of the coronary arteries. I know that's a popular screening method nowadays as well. I think all those things are important. Checking the prolactin level, like we had talked about, to making sure that there's not some sort of pituitary problem. But I think a lot of times unfortunately, we don't find a good reason. And I think that frustrates a lot of patients. And so, and then it's a complex issue. It can be a relationship issue. We're seeing a lot in young guys who are watching a lot of porn online, finding that the stimulation from the porn causes the brain to become almost desensitized, decreasing like chemical release. And so they can have ED from the lack of excitement from watching too much porn, and also the fact that reality doesn't compare to what they might be watching in these images.
Right.
So that's become an issue. So I will ask those kind of questions, especially in the 20-year-old guy who comes in with ED. Then you put in that whole kind of other side of things, anxiety, performance anxiety. If it happens once, it can be, something that you're thinking about from then on. So there's a lot of different factors that go into it, and it's kind of hard to separate out what the exact cause is a lot of times. But the good news is we have a lot of easy treatments like tadalafil, sildenafil, also known as Viagra and Cialis, or other way around, but that we can kind of treat you with initially. And the daily tadalafil, the daily Cialis, has been a great option. In the past, those things were very limiting by cost, but you can get 90 tadalafil tablets through GoodRx for like $40. So it's really changed dramatically who can, be on those medications. And, kind of along the lines of Men's Health, when you think about daily tadalafil, it's kind of a wonder drug for various reasons, because originally those meds were created as blood pressure medicines. So they lower your blood pressure. And then they found in the studies that side effect, and they said, wait, we're sitting on a gold mine here. But so it lowers your blood pressure, and it does so by dilating your blood vessels. And we know that a stroke is not enough blood flow to the brain. We know a heart attack is not enough blood flow to the heart. So you're essentially dilating those blood vessels to both the heart and the brain. They've shown that guys who are on Viagra had less dementia than guys who didn't take it. For that same reason, is that you're getting more blood flow to the brain. They even found that the brain tissue was healthier. And then, daily tadalafil is approved for enlarged prostate and enlarged prostate symptoms. And so you're looking at kind of a drug that essentially a lot of people are afraid of those medicines, but it's I would say really, I would argue that maybe all men over the age of 40 should be taking a daily tadalafil for that reason. Really you're increasing your nitric oxide. Some people would argue that might help your performance in the gym as well. So for a lot of reasons, daily tadalafil is a great drug.
Yeah. And I'm glad, that's great points that you made there. I think one of the major points and one of the reasons I sometimes get patients is because of those expectations, those false expectations set on you of who you're supposed to be, how you're supposed to perform, how you're supposed to look. And I will get the occasional patient who comes in and says, hey, you know what, I feel I'm not normal. Well, by what standards, right? And so I think that having a physician, having a provider who listens to their patients and can get down to the bottom of, is this psychological? Is this physical? Is this a sign of some other internal problem that's going awry, is really important,
Right.
So.
And I think a lot of those medications you're getting from the online pharmacies are basically just smaller doses of, tadalafil or sildenafil. They may put them in a combo pack. But really it's the same thing, but what you're not getting is that other side of it that we're talking about, right? They're just, you go online, they write your prescription, you take your drug and you go. And for some people that may work fine. But I think you're not getting that other side of it. And sometimes the medicines fail, and you have to kind of go to those next levels. And I think the population that you're talking about, those patients with metabolic syndrome, diabetics who have bad blood glucose control, they're going to be the ones who are going to fail the medicines because they also have nerve damage. They also have poor vascular disease. And so we have to go to kind of next level treatments for ED.
Absolutely.
And kind of while we're on the ED thing, one of the things I get a lot of questions about is this Shockwave treatment. Same thing we use essentially for kidney stones, but at a kind of different level, where they're shocking the blood vessels with this treatment. It's not really FDA approved for that. It's not really been proven to be very beneficial, but there's a lot of gimmicky clinics out there doing that, especially in the DC area. So just would caution patients on that. I've had guys who have said, I spent $5,000 and didn't do anything, and so if we can save patients from kind of going through that process, I think that would be great.
Yeah, greatly appreciate that, because unfortunately there are a lot of opportunities to make an extra dollar off of our patients, and I think that again, part of what we're trying to do here is advocate not only for the specialties, but also advocate for patients and making sure they're vetting the sources of information that they're following. So
definitely.
Great. I mean, I really appreciate you coming in. This has been incredibly eye-opening. I know patients, our audience are really going to appreciate it. And like I said, hopefully in the future, if we have any questions or other topics come up, we'll have you back here and just to keep educating us. So thank you very much.
Yeah, I appreciate having me. I think it's very important stuff, and I think just kind of to illustrate, I mean, 50% of guys in their 40s will have ED issues. And so it is something that is just not talked about, but is very relevant to our population. And I think I would just encourage guys not to just sit at home suffering, go and talk to somebody about it. And I'm really happy that you gave me the opportunity to kind of speak to your patients.
Well, thank you so much. We appreciate it. And so we want to thank everybody for tuning in, and please follow us and tune in next time for some more information. And thank you very much. And thank you, Dr. DeCastro. Appreciate it.
Great.
Awesome. Before we wrap up, I want to remind you that this podcast is for educational and informational purposes only. While we talk about health, weight loss, and wellness, this is not a substitute for professional medical advice, diagnosis, or treatment. Nothing in this podcast creates a doctor-patient relationship, and any health decisions should be made with the guidance of qualified healthcare providers. If you have medical concerns, I strongly encourage you to consult with a professional before making any changes to your health routine. The insights shared in this podcast, whether from me or my guests, are meant to educate and empower you, and they should never replace personalized medical care. Always seek professional guidance when it comes to your health. Thank you for tuning in, and we'll see you in the next episode.